Welcome to this deep dive, specifically for all you orthopedic residents out there, getting ready for those big exit exams like the FRCS.
Yeah.
So we're going to really dive deep into surgical approaches, focusing on the distal femur, the tibia plateau,
Yeah.
and the ankle.
Oh, that sounds good.
And to guide us through this whole journey, we've got the Ortho Made Simple notes, right?
Yeah.
From mokyingren.sg.
Yeah, they're really good.
And these notes were actually put together by Dr. Mok Ying Ren,
Yeah.
who's
The
a
sports surgeon.
sports surgeon at the National University Hospital in Singapore.
Yeah.
And what's really cool is he aced his FRCS exam back in 2022.
Oh, wow.
So we're in good hands.
Definitely.
So let's get started with the distal femur.
Okay.
When we're talking about surgical approaches, what's the first one that pops into your mind that we really need to know?
So for the distal femur, the lateral or anterolateral approach is kind of the gold standard.
Okay, so that's the one.
It gives you the best view, and it's really versatile.
Okay, so it's all about that clear view.
Yeah, exactly. You want to be able to see what you're doing, right?
Right.
Minimize the risk of damaging anything important.
Of course.
And it's adaptable.
Yeah.
You can extend it if you need to get into the joint.
Makes sense. So could you walk us through the steps of this approach?
Absolutely.
I mean, I think everybody listening wants to kind of picture this.
So imagine your patient lying on their back
Okay.
with a little bump under the knee.
Okay.
Your incision follows the line of the femur heading towards Gerdy's tubercle.
Okay.
You'll go through the iliotibial band, or ITB,
Right.
and then you elevate the vastus lateralis muscle.
Okay.
But this is important. Those perforating vessels from the profunda femoris artery, you've got to ligate them.
Right.
They can bleed a lot if you're not careful.
Gotcha.
And if you need to get into the knee joint, a lateral parapatellar arthrotomy will do it.
Okay, so that's our primary approach for the distal femur.
Right.
But what happens if you need to, put in a medial plate for extra stability? Are there other approaches we should be thinking about?
Yeah, so if you need a medial plate, you've got a couple of options.
Okay.
The medial subvastus approach and the medial parapatellar approach.
Got it.
So the subvastus one basically goes between the sartorius and the vastus medialis oblique.
Okay.
That's your VMO.
Yeah.
Gives you a clear path to the medial side.
Right.
The medial parapatellar approach runs alongside the patella,
Uh-huh.
using that natural division between the VMO and the rectus femoris.
I see.
So, yeah, you got two options there.
Now, I remember hearing about the lateral parapatellar approach
Okay.
during my rotations,
Yeah.
but it wasn't really used very often.
Ah, yes. The lateral parapatellar or swashbuckler approach.
Yeah, the swashbuckler.
It does give you good exposure,
Okay.
and it's handy for dual plating.
Okay.
But we tend to avoid it because it can cause problems later on if the patient needs a total knee replacement.
Yeah, we don't want to cause problems down the line if we can avoid it.
Ex-
All right, so we've covered the distal femur pretty thoroughly. I think everyone listening has got a good grasp of the key approaches there.
Yeah, I think so.
So let's move on
Okay.
down the leg to the tibia plateau.
Okay.
Another area with,
A lot of trauma.
quite a bit of trauma.
Yeah.
So what's the most common approach we use for the tibia plateau?
The anterolateral approach is the workhorse for the tibia plateau.
Okay, so anterolateral again?
Yeah, it's our go-to for most fractures in this area.
So how does this differ from what we were talking about with the distal femur?
Okay, so imagine your patient's in the same position,
Okay.
lying on their back.
Fine.
Now picture a hockey stick, but flipped upside down.
Okay.
That's the shape of your incision.
Right.
It starts just below the knee joint line, curves around Gerdy's tubercle,
Yeah.
runs along the side of the patellar tendon,
Okay.
staying about a centimeter away from the tibial crest.
Right.
Then you go through the fascia, elevate the tibialis anterior muscle, and then do a submeniscal arthrotomy to get into the joint.
So pretty different approach then.
Yeah, a bit different.
Okay, what if you're dealing with a complex fracture that needs coronal dual plating?
Okay.
Would you still use the anterolateral approach?
So for those tricky situations where you need coronal dual plating,
Yeah.
the posteromedial approach, or the Lobenhofer approach,
That's-
is really useful.
Okay.
It lets you get at the back of the tibia plateau,
Right.
which is essential for those medial plates.
That makes sense. So how does the posteromedial approach differ from the anterolateral one?
Okay, so instead of going between the tibialis anterior and those extensor muscles,
Right.
like we did in the anterolateral approach,
Yeah.
the posteromedial approach uses the space between the semimembranosus and the medial gastrocnemius muscles.
Okay.
Your incision starts at the medial epicondyle of the femur
Right.
and goes down towards the posteromedial edge of the tibia. Then you carefully dissect between those muscles.
Right.
Do some superiostele elevation of the popliteus muscle.
Okay. And work your way down to the joint capsule.
Now, are there any other approaches for the tibia plateau that we should be aware of for the exams?
Oh, yeah, absolutely.
Okay.
So remember, the tibia plateau can be approached from all sorts of angles,
Right.
depending on the injury
Of course. Yeah.
and what you need to do surgically.
Yeah.
So if you're dealing with a PCL avulsion
Yeah.
or need to get to the posteromedial side,
Uh-huh.
the posterior approach is your best bet.
Okay.
This involves a slightly curved incision,
Right.
and you need to be really careful of the popliteal neurovascular bundle.
Yeah, of course.
That's the artery vein and nerve behind the knee.
Right.
Then you've got the posterolateral approach,
Okay.
often combined with a fibular osteotomy,
Uh-huh.
which gives you access from the lateral side.
I see.
And lastly, you've got the medial approach.
Yeah.
Same incision and plane as the posteromedial approach.
Okay, great. So we've covered quite a bit there with the distal femur and the tibia plateau approaches.
I think everyone could use a moment just to let that sink in.
Yeah.
But remember, all of this is coming from those Ortho-Made Simple notes.
Yes.
Available at mokyingren.sg.
They're a great resource.
They are a fantastic resource, especially if you're gearing up for those exams.
Definitely.
When we come back, we're going to tackle those ankle and distal tibia approaches.
Sounds good.
So stay tuned. Okay, so let's get back into these surgical approaches.
All right.
We've done the distal femur and tibia plateau.
Yeah.
Now it's time for the ankle and distal tibia.
Okay.
These are tough areas, right?
Oh, yeah. They can be tricky.
Because there's so much going on down there.
It's a high traffic area, right?
Yeah, exactly. A lot of weight bearing, a lot of movement.
Exactly. So you get these really intricate fractures.
Yeah. And when those fractures happen,
Yeah.
we need to be super precise with our approaches
Oh, absolutely.
to make sure everything heals properly.
You want to get that function back.
Right, exactly.
Yeah.
So let's start with pylon and talus fractures.
Okay.
What's the go-to approach for those?
For pylon and talus fractures, the anteromedial approach is our workhorse.
Okay, anteromedial.
Yeah, it gives you good access to the front and inner side of the ankle joint.
So that's essential for these types of injuries.
It is, yeah.
Can you walk us through the anteromedial approach?
Sure.
What are the landmarks? What are the steps?
All right, so picture this.
Okay,
Your patient's lying on their back.
okay.
You're working on the inside of the ankle.
Uh-huh.
Your incision is just in front of the medial malleolus.
Okay.
That's that bony bump on the inside.
Right, right.
Now, here's where it gets delicate.
Okay.
You have to be really careful of the long saphenous vein and the saphenous nerve.
Oh, yeah, of course they're right there.
They are.
You don't want to damage those.
How you do?
Big problems.
Yeah.
So as you're dissecting through there,
Yeah.
you retract the anterior tibialis muscle
That's right, laterally.
laterally.
Yep, and then you do a capsulotomy to open the joint capsule.
Okay, so meticulous dissection,
Yes.
nerve protection key.
Absolutely.
But what if for some reason the anteromedial approach isn't a good fit?
Okay.
What are other options for getting into that ankle joint?
Well, if the anteromedial approach isn't suitable, the posterolateral approach is a solid second choice.
Okay, so posterolateral.
Yeah.
And is that ever used together with anteromedial?
It is actually, we often combine the two
Oh, wow.
for a dual incision technique,
Interesting.
especially when dealing with those complex talus fractures.
So why two incisions?
Well, sometimes to really get a good look at the fracture,
Yeah.
especially in a bone like the talus,
Uh-huh.
we need to come at it from different angles.
Makes sense.
So by using both anteromedial and posterolateral incisions,
Yeah.
we get better stability during fixation.
Right.
And we can be sure we're addressing all parts of that fracture.
So it's like having two sets of eyes,
Exactly.
two sets of hands,
More control.
better control.
Mm.
Okay, so let's talk posterolateral approach.
Sure.
What are the landmarks, the danger zones?
Okay, so with the posterolateral approach, you're working on the outer side of the ankle.
Okay.
Your surgical plane is between the peroneal muscles
Huh.
and the flexor hallucis longus muscle.
Okay.
So you're finding that sweet spot between muscle groups
Right.
to minimize disruption,
Yeah.
but you've got to be super careful of the sural nerve,
Right.
which then becomes the lateral dorsal cutaneous nerve.
Yeah.
Don't want to damage that.
Sensory problems in the foot.
Exactly.
Okay.
So your incision goes between the Achilles tendon and the fibula,
Right.
and as you dissect, you're meticulously protecting that sural nerve,
Uh-huh.
the peroneal tendons,
Yeah.
and then you carefully elevate the flexor hallucis longus to get to the joint.
Okay, so anteromedial, posterolateral, those are our two big ones for the ankle.
Right.
But I'm guessing there are other more specialized approaches we should know.
Oh, yeah, absolutely.
It's not always that straightforward.
No, it's not.
So what else is out there?
Well, the interlateral approach can be used with the anteromedial approach for that dual incision approach to the talus.
Right, right.
The anterior approach is often preferred for total ankle replacements,
Okay.
where you're replacing the whole joint.
Makes sense.
And for those posterior malleolus fractures,
Uh-huh.
the postremedial approach comes into play.
Interesting. So we've got all these open approaches.
Yeah.
What about arthroscopy?
Oh, yeah, ankle arthroscopy.
Minimally invasive, but I bet it comes with its own challenges.
It does.
What do we need to watch out for?
Well, ankle arthroscopy is a great tool.
Yeah.
It lets us diagnose and treat a lot of different ankle problems
Right.
with minimal disruption.
But-
portal placement is critical.
Okay.
We need to be very aware of the anatomy,
Yeah.
especially that superficial peroneal nerve.
You don't want to hit that?
No, you don't.
Okay. So that's a lot to take in. We've covered distal femur tibia plateau and now the ankle.
Cute.
And all of this comes straight from those Ortho Made Simple notes.
Yep.
That you can find at mokyingren.sg.
Easy to remember.
Easy to remember. They were put together by Dr. Mok Ying Ren.
Great resource.
A fantastic resource, especially if you're getting ready for those orthopedic exams.
Couldn't agree more.
All right, welcome back to our deep dive into these surgical approaches that you really got to know for those orthopedic exams.
Yeah, it's been a lot.
It has been a lot. We've gone from the distal femur, the tibia plateau, and all the way down to the ankle and distal tibia.
Quite a journey.
It really is. And I got to say, having these Ortho Made Simple notes from mokyingren.sg
Yeah.
has been like having a roadmap.
Yeah, it's been really helpful.
Right, because, you can read about these approaches in textbooks, but it's not the same as really visualizing them
No, it's not.
and understanding those little nuances.
Yeah, Dr. Mok Ying Ren did a great job of making it all clear and concise.
He really did. It's a fantastic resource for any resident who's, facing those exams.
Definitely.
Really is.
And as you go through your training and you get that hands-on experience,
Yeah.
you start to appreciate those subtle differences between the different approaches and how they actually affect the outcome for the patient.
Yeah, yeah. And I think that's what makes surgery so fascinating.
It is.
It's like this blend of science and art
It is.
and your own experience.
Right.
You take what you learn from the books,
Yeah.
you apply it in real life,
Yeah.
and then you kind of refine your technique over time.
Yeah, you're constantly learning and refining.
Exactly.
And with each case you gain a bit more confidence.
You do. You really do.
And you become a more skilled surgeon.
So this deep dive, I think, has been really insightful.
It has.
And everyone listening is probably feeling a lot more prepared for those exams.
I hope so.
But remember, this is just the beginning.
Oh, yeah.
There's always more to learn.
Absolutely.
In orthopedics, there's always new techniques, emerging new things to explore.
It's a constantly evolving field.
It really is. And that's part of what makes it so exciting.
It is. It keeps you on your toes.
So for all you residents out there, hitting the books,
Yeah.
getting ready for those exams, best of luck.
You got this.
You got this. And if you're feeling a little overwhelmed,
Take a deep breath.
head over to mokyingren.sg.
Check out the Ortho Made Simple notes.
They're a fantastic resource.
Yeah.
They can really help make those complex concepts a little bit clearer
Definitely.
and give you that edge
That extra edge.
to succeed. So keep those brains buzzing,
Keep learning.
and we'll catch you on the next deep dive.